Dr. Lobo,
Yes.
you can start the meeting now, sir.
Okay. So, good evening, everybody. The topic that Dr. Kher asked me to cover today was on practical aspects of dialysis, which is what I will do. I'm now going to share the screen. Yeah. Is it visible? How long do we have today? Right. So I'm going to maybe take about 30 to 35 minutes, maybe 40 minutes at the most. And if we have time thereafter, let's make it as interactive. So let's have lots of questions from you and discussion, and let's see how we go from there. So, as an outline, what I kept was care and monitoring of vascular access, fever on dialysis, infection control, aspects of catheter-related bloodstream infection, hypotension, because that's probably the most common thing that we all get calls for on dialysis. And then I've added air embolism, hemolysis, and dialyzer reactions, which I have not shown on this slide. So I acknowledge the my colleagues from the Indian Society of Nephrology Hemodialysis Working Group and my colleagues in the Department of Nephrology, KEM Hospital, Pune, for whatever I'm going to tell you today is sort of a synthesis of what we have learned over the years. So we'll start with vascular access care, and this slide from Svetlana Kacharova says that vascular access care has to be a continuum. And so we need to today have a vascular access program. Vascular access programs would start with assessment of the vascular access, and ideally, it should be done every day for every patient in every shift of dialysis. What we are supposed to do is to look, listen, and feel the AV fistula and document what we have. That will enable us to early pick up dysfunctions, intervene when there is a dysfunctional vascular access, then monitor the vascular access once again, surveillance and monitoring after we have intervened, and again assess when there is dysfunction. And so the continuum goes on. So, what is the difference between monitoring and surveillance? The physical examination to detect physical signs that suggest dysfunction is monitoring, and evaluation by means of specialized tests or instruments is called surveillance. Surveillance and monitoring are complementary, so neither of them will work alone, and they need to be tracked within each center as part of quality assurance. And diagnostic testing, that is, special tests like ultrasound or angiography, will need to be undertaken where necessary. Physical examination is perhaps the most valuable tool because anybody can do it. It doesn't require expensive machinery. It can be done whenever we want to do it, and it doesn't involve any risk to the patient. It includes the usual inspection, palpation, and auscultation in what is called as the 1 minute fistula examination. So just in within 1 minute, it is possible to assess a fistula prior to cannulating it for hemodialysis. And what do we look for? The number and position of scars, the rule of six, which we all know, that is a well-working fistula should have a length of at least 6 centimeters for cannulation. The vein should be at least 6 millimeters in diameter. The fistula should be at least 6 weeks old, and it should not be more than 6 millimeters deep for cannulation. We look for the presence of accessory veins, and a normal capillary fill would rule out a steel or otherwise ischemia of the arm. Abnormal inspection means pseudoaneurysms, arm swelling, visible collaterals, redness, purulent discharge, or swelling could indicate infection, or in some situations, redness, swelling, and even a breakdown of the skin with oozing of edema fluid could indicate venous hypertension. A graft has two scars, and a fistula has one scar. In the case of a forearm fistula, it's at the wrist. In the case of an upper arm fistula, at the elbow. If a graft is a loop in the forearm, then one limb of the graft will be the arterial and the other will be the venous, and it is necessary to occlude each of these to find out. When we occlude the venous limb, the arterial limb, if we palpate the arterial limb, it augments. And if we occlude the arterial limb, then obviously no thrill or pulsation is felt in the venous limb. Now, unlike an AV fistula, which is where you have a length of vein to cannulate and it doesn't really matter where you cannulate it, in the arteriovenous graft, whether it's a synthetic graft or a saphenous vein graft, it's necessary to know which is the arterial and which is the inflow and which is the outflow limb in order to direct the needles appropriately for doing dialysis. And of course, if you have a long scar extending from the axilla to the elbow, that generally means a transposed basilic vein. Now, here you can see an AV fistula, which is a left radiocephalic. You can see that the right wrist, the right forearm, and the right dorsum of the hand is absolutely normal. You look at the left side, it's swollen, it's unseemly. There is a blackish discoloration of the skin here. So, this is venous hypertension, secondary to a stenosis upstream of the fistula. And this is, of course, the worst thing that one can see. You have a right brachiocephalic fistula, and you have swelling over the chest wall, you have gross swelling over the neck, the face, and this patient will be complaining of breathlessness. This is the superior vena cava syndrome, the most dreaded complication of a central venous stenosis with a functioning AV fistula, a high volume fistula at that. When we palpate, we look for a presence of a continuous thrill, the springy feel of the vein, no water hammer pulses, and auscultation should have a continuous low pitched bruit. A pure systolic high pitched bruit indicates a local stenosis. We move on to uh, carrying out the augmentation test and the arm raising test, where the collapse of the AVF downstream of a lesion indicates the presence of a venous stenosis. So, to summarize, if you have a well developed straight segment which can be cannulated and no aneurysmal spaces which collapses, that's a normal AVF. A uniform straight or loop segment without localized dilatations, good AV graft. If you have a maturation problem, you could have multiple collaterals without a well developed cannulation site. The AVF could have narrowing or aneurysm, and a graft, the commonest site for a graft stenosis, is the outflow into the outflow vein. Infection or steel redness, color changes, or cyanosis in the hand. The bruit should be low pitched and continuous. It shouldn't be high pitched. And the thrill should be all over with an easily compressible vein. In a graft, the thrill is strongest at the arterial, but is felt all over. If you have a water hammer pulse, that's a stenotic segment, poor compressibility, warmth and swelling, cool and painful limbs, that's steel. After we have examined the AV fistula, what we can go on to is cannulation. What we would normally do is to ask the patient prior to reaching the dialysis center to wash the access limb with a soap. Any soap would do, it doesn't have to be an antimicrobial soap. Soap and water. We wash our hands, wear sterile gloves, and then clean the skin by applying alcoholic chlorhexidine. The advantage of alcoholic chlorhexidine, apart from having been shown to be superior to povidone iodine in skin preparation, is that povidone iodine sometimes discolors the skin and makes it more difficult to cannulate an AV fistula, which is easy when you use alcoholic chlorhexidine, which is a clear solution. You clean in with a circular movement. Change gloves if they get contaminated at any point of time. Most importantly, allow the antiseptic to dry on the skin, which means about 40 seconds for alcoholic chlorhexidine or isopropyl alcohol, whereas betadine, povidone iodine, takes about 2 minutes to dry. We use a 26 gauge needle with 2% xylocaine. That's an insulin needle to infiltrate the puncture site with local. Remember, a 26 gauge needle is virtually painless, but 17 or 16 gauge needles required for the AV fistula can be very painful, even more so if more than one attempt is made at cannulation. So I have used all three. I've used an ethyl chloride spray. We use that Prilox gel, which is a combination of lignocaine and prilocaine, and I've used 26 gauge needle to infiltrate with an insulin syringe. And patients tell me that the maximum pain relief is felt with infiltration with 2% xylocaine. This is from the Indian Society of Nephrology cannulation technique guidelines. Railroading technique rather than buttonholing. So, in a rope ladder or railroading, each puncture should be 1 to 2 millimeters away from the previous, and after around 6 to 7 sessions, we return to the original. Needle should be inserted at around 45 degrees and then made parallel to the skin, and the needle should be sighted. Now, it's often said that the arterial needle should point towards the anastomosis at a 3 centimeter distance, and the venous needle should point away. That's not always feasible, especially if you have a relatively short cannulation segment. In such a situation, it doesn't really increase the recirculation if you direct both needles away from the anastomosis. And both the needles should, however, be at least 5 centimeters from each other where possible. Uh, Blood in the extracorporeal circuit should be returned using saline rather than air. Air has, apart from the risk of triggering off, and when you go into a return mode, then some machines, air detectors, may not work, which allows the danger of an air embolism. In addition, when air enters a dialyzer, especially if you are going to reuse dialyzers and fill them with disinfectant, incomplete filling of the dialyzer with the disinfectant might occur if there are a large number of air bubbles. So saline rather than air to return blood. It's generally not a problem if you know the volume of the extracorporeal circuit. The average dialyzer is about 75 to 80 ml, and the circuit is about 100 to 120 ml. So generally, if you use about 150 to 200 ml of saline, you are in no danger of infusing saline to a patient. After the needles have been removed, pressure to be applied to the puncture site with a sterile gauze pad for about 10 minutes, and this will stop the bleeding unless the fistula has a proximal stenosis. After that, a dry gauze with sticking plaster and no tourniquets to be applied to an AV fistula limb after needle removal. Now, the application of tourniquet has two drawbacks. In the first place, when a tourniquet is applied, the time for which a fistula bleeds after needle removal is not evident. So, one of the signs of venous hypertension, one of the earliest signs, even before limb swelling occurs, of venous hypertension, even central venous stenosis, is a prolonged bleeding from the needle site and a difficulty in stopping the bleeding with pressure. Now, if a tourniquet is applied because either the nurse is in a hurry or the patient is in a hurry, or it cannot be bothered to take the trouble of giving pressure for 10 minutes, then in that situation, you may miss the early sign of venous hypertension. And there is some evidence also that if you have a stenosis already existing and you then apply a tourniquet and stop the flow, you produce the second of Virchow's triad. So you already have an altered flow, and then you add to that turbulence, you add a further perhaps damage to the endothelium which has been caused by the needles, and you would be increasing the chances of a fistula thrombosing. Now, this is what you would not like to see. This is a typical buttonholing puncture. The punctures have been made. There's an entire length segment of vein over here of a fistula which has not been cannulated. All the cannulations have been done in this point and in this point. So this is a localized cannulation technique. It's sometimes mistakenly called buttonhole, but the true buttonhole technique is actually meant for blunt needles, which most centers here do not have. So when sharp needles are used in this form of cannulation, a more precise terminology is that this is a localized cannulation technique, and it has some very bad consequences. This is an aneurysmal dilatation which has developed here and here and here because of area puncture or localized cannulation technique, which locally weakens the wall of the vein, and then a blowout occurs, and then you have an aneurysmal dilatation. You have an even weaker segment which is becoming weaker and increases your risk of one day the fistula rupturing. Okay, so much for AV fistulas and AV grafts. We also have an increasing use of tunnel cuff catheters in our dialysis units, and we need to, it's said that nephrologists hate cannulas but cannot live without them. So we face this conundrum, and therefore if we cannot live without them, we at least have to take all possible care of them. So we need to inspect the exit site for redness or purulence. We need to give some pressure over the tunnel to make sure there isn't tenderness or localized collection. And then the ISN guidelines recommend that the CDC scrub the hub protocol should be used when connecting and disconnecting patients. When you scrub the hub, It's not only the alcoholic chlorhexidine that is important. The CDC guidelines stress that it is the friction, the force and the friction that you apply to the threads of the hub that is important, because that removes soiling with dried blood or other residue in the threads of the hub of a cannula. So scrubbing the hub with adequate force and adequate friction is important, as important perhaps as the disinfectant being used. It's preferable to use a triple sporin antibiotic ointment as opposed to mupirocin, because, as I'll show you a little later, in India, in hemodialysis units, and I saw one today also, just saw one patient in the ICU who has come from an outside hemodialysis unit, whose blood culture has grown an organism called Stenotrophomonas maltophilia. So what we will often get is these type of rare organisms which are water organisms, and they are all gram negative organisms. So staphylococcus aureus, unlike the western literature, may not be as large a problem for us in India as the gram negatives which are coming from our water. They come from the municipal water and they come from our treated water, and so it may be better to use a neomycin bacitracin polymyxin B ointment, again, which is more active against gram negative organisms than the mupirocin, which is against staphylococcus aureus. Importantly, when filling the catheter with the anticoagulant, it's important to give a pressure on the piston of the syringe continuously till the clamp is applied, so that blood does not flow back into the catheter and clot it. This is a table taken from the guidelines. It's available in the guidelines, and what it does only is to tell you that the various materials of which catheters are made need to be assessed for their compatibility with the antiseptic we apply to the skin and the antimicrobial ointment that we apply. So as you can see here, I just said a few minutes ago that I prefer the triple sporin ointment, but with polyurethane and silicone catheters, as per the CDC website, mupirocin compatibility is shown, but we don't yet know about triple sporin compatibility with this particular, with the Medcomp and the split catheters. When do we know that a catheter is malfunctioning? If our dialysis, if our negative pre-pump pressure, known as arterial pressure sometimes, is very negative, less than minus 250, or the venous pressure is more than 200 plus 250, then that indicates that a catheter is not giving the desired flow and we need to investigate it. If we get frequent high pressure alarms, if we aren't getting the blood flow, if the nurses, and this is something that we need to have a protocol within our unit to do, if the nurses frequently reverse the lines without informing anybody, it could be a long time before you find out that there is a catheter malfunction, and by that time it may actually be too late to intervene, or too late to intervene safely within the dialysis unit, and it might need specialized intervention. So if a nurse is reversing lines, it's important that she inform the resident doctor or the nephrologist in the unit so that they know that a catheter malfunction has started. A ball valve mechanism operates with a fibrin sheath in the catheter, wherein it's easy to flush saline into the lumen, it moves freely, but when you attempt to aspirate from a lumen, nothing comes, because the fibrin sheath is then sucked against the holes of the catheter. So that ball valve mechanism would generally indicate a fibrin sheath in the vein over the catheter. This is a technique which I use in AV fistulas. It's called the hematocrit dilution technique, was described in 2008 and validated against an ultrasound technique. It's based on the law of mass balance. What you do is at the start to draw a sample from the arterial needle for hematocrit, then reverse the line so that you are infusing saline into the arterial needle, and after 12 seconds, draw a sample from the venous lumen. Now, the flow coming to the venous needle at this point is a combination, or the blood flow in the fistula has been diluted by the blood by the saline that is being infused into it by the machine's blood pump. So if we know the machine's blood pump, we know the machine blood pump speed, then we can calculate, and we know how much the hematocrit has been diluted or decreased by infusion of saline, then we can calculate the excess blood flow. Some of the problems that arise on hemodialysis, of which the commonest is possibly hypotension. Cramps can be very troubling to a patient. Nausea, vomiting, headaches, chest and back pain, pruritus, fever and chills, hemolysis, air embolisms, access hemorrhage, which is very rare. I'm fortunate to have not seen it so far. venous needle dislodgement, about less than 100 per million sessions. Cardiac arrest, that's given as 70 per million sessions, but that's something that unfortunately many of us have seen. And dialyzer reactions, which are also becoming rare. So let's look for a minute at fever on dialysis, and it's defined as a rise in temperature of more than 0.5 degrees centigrade, or in terms of rectal and axillary absolute temperatures, which occurs during dialysis. Importantly, not all fevers during dialysis are fevers related to the dialysis procedure. So, for some reason, a systemic infection may manifest during the dialysis session with fever. I don't think I've ever found a satisfactory explanation for this, but patients will tend to get their fevers more often during the dialysis session, and not all fevers related to the dialysis will turn up during the procedure, but might follow it several hours later. Infective causes occur for about 70%, and they are mostly bacterial infections related to the vascular access, the dialyzer and tubings, or the dialysis machine, or systemic. But there are a lot of non infective conditions which can produce fever and chills on dialysis. So, pyrogenic reactions are by far the most common, and I'll cover that. Dialyzer reactions can present with fever and chills. Disinfectant toxicity, because the disinfectant has either not been washed out completely from the machine. Now, very fortunately, the most modern machines today have a program which will tell you that the machine requires a rinse if there is residual disinfectant present in the machine. Acute hemolysis can produce a fever on dialysis, and using too cold a dialysate will mean that the patient will have shivering but not and chills but no fever. So, what are the sources of nosocomial infection? The water treatment and distribution system, and I'll be taking this lecture about how to maintain the water treatment system on the 13th for the National Board. Stagnation and contamination of the bicarbonate concentrate. Bicarbonate is by far the richest medium for bacteria to grow. So, when we get into making, and it's a convenience for nursing staff, technicians to prepare bicarbonate solutions overnight when the unit is quiet and use them in the first shift in the morning. But allowing a bicarbonate concentrate to stand overnight gives a very large chance for the water organisms, the less fastidious organisms, to grow in that jar of bicarbonate. They then enter the machine during the dialysis, which occurs the next morning, and then colonize the machine hydraulics. And once you have a biofilm which forms within the machine, it can be extremely difficult to get rid of. So, importantly, don't allow bicarbonate to stand overnight. So, one reason is preparation. The other is that nurses and technicians feel that it is wasteful to throw away a half-used jar of bicarbonate, because less dialysis were done in the night session, and they will keep the jar over to use the next morning. So we have a very strict rule that all bicarbonate is to be poured away in the night. The bicarbonate mixer, if you have a mechanical stirrer for preparation of bicarbonate, is to be emptied at night and then cleaned and disinfected before fresh bicarbonate is prepared in the morning. Lower limb cannula, a commoner source than upper than internal jugular and subclavian, and mixing of disposables predisposes not only to bacterial infections but also to the dreaded hepatitis B and hepatitis C in the unit. This is something that can happen with disinfectants. Now, here you have two peracetic acid based disinfectants which are available. One of them has 4.5% of peracetic acid, while the other has 1.73%, though they are both peracetic acid based. One has 24% hydrogen peroxide and the other has about 6%. So the way in which you prepare a 2% solution or a 3.5% solution to fill your dialyzer, if you're reusing dialyzers, or a 1% solution for disinfecting accessories, either of these, a misuse or an interchange of either of these could produce a febrile reaction on dialysis. If you used the 4.5%, in the dilution which was meant for the 1.73% and filled your dialyzer with it, then the amount of rinsing of water with water that you required during the priming, or the amount of rinsing of the machine, might not be enough to remove all the disinfectant, and you could get a reaction to disinfectant because some disinfectant entered the patient's bloodstream during the start of dialysis. If you use the 1.73% with a dilution that was meant for 4.5%, then you would end up by over diluting your disinfectant. It may not be effective, and it may, in such a solution, in such a situation, actually allow bacterial growth within on either your accessories or within the dialyzer. The simplest way to find out that you are effectively using a peracetic acid based disinfectant is to use these test strips. Now, this one tests peracetic acid, and you can see from the color of the test strip that you could have a concentration of between 500 milligram per liter or parts per million to about 2000. So depending on what strength you require, and we usually would use between 1000 and 1500 for most situations to allow adequate disinfection, you need to test your disinfecting solution. The second one tests hydrogen peroxide. Now, in the first, you might end up by knowing that you are making an inadequate strength of solution. In the second, you need to have it as low as possible. So the hydrogen peroxide, which is far more difficult to remove than peracetic acid, tells you that the residual disinfectant has been completely removed. You should have a negative or a less than 0.5 milligram parts per million when you test your solution with the test strip. What is a pyrogenic reaction? Low grade fever generally starts, but it could go up to shaking, chills, visible rigors, temperature going up then to 39 or 40 degrees. Tachycardia usually occurs before the chills, and about 1/5 to 1/4 of the patients will get severe hypotension with and may even need so not only fluids but even noradrenaline for a period of 6 to 8 hours. Headache, myalgias, nausea. This may also be seen in an infected dialysis cannula. The reason being that water organisms tend to produce a slime polysaccharide layer, and so can form a biofilm even within a cuff tunnel catheter, and then that biofilm can release endotoxin during dialysis. So the pyrogenic reaction is caused by dead bacteria or their products like endotoxins. There are some DNA fragments and low molecular weight endotoxin fragments which can cross any membrane, whether it's a dialysis membrane or an RO membrane. And unfortunately, the LAL test for endotoxin does not detect these. You would need to do a cytokine release assay to find out. This is what I showed in the lecture on water treatment, that you can have a situation in which your carbon tanks remove chlorine and increase the amount of bacterial contamination. The RO takes care of that, so your endotoxin goes down, and then once you start using bicarbonate in the dialysis fluid, the endotoxin level could go up again. If you are using a Fresenius or a Gambro machine which has an endotoxin filter built into the dialysate part, then that ultrafilter should take care of the endotoxin. But you need to make sure that the endotoxin filter is actually present, that it is working in satisfactorily, and that the test that the machine should do, the cyclic pressure holding test, has not been bypassed. So catheter-related bloodstream infections, you need 3 sets of cultures, and it has been shown that the more you take, the more blood you culture, the higher the yield. So the ISN guidelines currently recommend that even if a catheter is being removed, we should collect blood for culture. If you collect about 30 ml of blood, then you increase your yield of cultures to around 60% as compared to 15 to 20% if you use 10 ml of blood. And of course, there are smaller recommendations for pediatric and neonatal patients. There are not many neonates who will be on hemodialysis. And if you are using, if you're taking blood as per a pediatric, in a pediatric patient, you need to ensure that you use the right bottle, because the dilution of the blood culture bottles is meant for the lower amounts. And if you over dilute it by using an adult blood culture bottle, then you may not get a yield of blood culture. So Shaman Locke mentions that strict adherence to the IDSA criteria is not required for the dialysis. In fact, the IDSA criteria refers specifically to central venous catheters used for intravenous access and not for hemodialysis catheters. So we may not need to go strictly by the time to positivity and differential positivity rates or differential colony counts mentioned in the IDSA criteria. If a patient is symptomatic and if all three cultures grow, that is the catheter lumen and the peripheral culture grow organisms, it may be good enough to start treatment. And finally, although many labs will have the BACTEC and VITEC automated systems, no matter how automated your system is, it needs somebody to be present in the lab to note that that bulb is flashing when the BACTEC culture becomes positive. The ISN guidelines recommend not using empirical vancomycin for treatment. And that is the reason for that is what I mentioned earlier, that more often than not, dialysis patients will have a gram-negative organism from the water and not Staphylococcus aureus. So using vancomycin may delay treatment with an adverse outcome as well as promote the development of skin commensals, that is the coagulase negative staphylococcus, becoming vancomycin resistant. Should those organisms then colonize a dialysis catheter, you would have a vancomycin resistant staphylococcus. So it's recommended that dialysis units should maintain a record of the organisms, which enables you to have an antibiotic policy and know that when you draw a culture, if your commonest organisms are gram negative, then no empirical vancomycin. Choose a culture as per the results of the surveillances of the last 6 months, and that's what we generally do. And this is what is our data for 2019-2020. Total blood cultures of patients dialyzing in KEM as well as those who came to us with fever who were dialyzing elsewhere, we did a total of 198 cultures. 50% of our cultures grew organisms, and that in sort of underscores the importance of drawing at least 30 ml of blood for culture and not going by 10 ml in one bottle. The more you draw, you get a 50% culture rate, and our culture rate from the dialysis unit is 50% as compared to the hospital average, which stands at around 18%. So more blood, better cultures. And the commonest organism is Burkholderia cepacia, which is a water organism. And along with it, you've got Proteus, Pseudomonas, Ralstonia piqueti, Stenotrophomonas, Aeromonas, all of these organisms which are non-fastidious water-growing organisms. So we need to therefore plan our empirical antibiotic therapy according to the common organisms and their sensitivity. And this is another paper from India published in the International Journal of Advanced Medicine by Chandra in 2016, which also shows that there is a significant number of, in this 42 positive samples, gram-negative organisms are significantly high as well, and more common perhaps than MRSA and MSSA. When they had gram-positive organisms, there was 100% sensitivity to linezolid, but the overuse of ticoplanin is responsible for Enterococcus now developing resistance to ticoplanin, and that may become a problem in the near future. So femorals are catheters are more likely to have bacteremias than IJVs, and subclavians have the lowest rates of all. But we in dialysis units do not use subclavian catheters because the rate of subclavian stenosis with a dialysis with a tunnel cuff catheter with a subclavian catheter is about 40%, 30 to 40%, and it's only about 10% with an internal jugular catheter. So can we prevent catheter dysfunction by using solutions other than heparin? The pre-clot study was published in the New England Journal of Medicine about 10 years ago, where the midweek dialysis, they used tissue plasminogen activator to lock the catheter, whereas the first and the last of the week dialysis, they used heparin. And that was in the control group got heparin in all three, and overall catheter malfunction was significantly lower in the TPA group as compared to the heparin group. And most importantly, forget about catheter malfunction, because that was the main aim of the study. Catheter related and all-cause bacteremia rates were also lower in the TPA group compared with the heparin group. The only problem for us in India is that tissue plasminogen activator as 1 milligram injection vials is not available. The lowest strength available is 10 milligrams, and that costs about 25,000. So this is not a practical solution, but we have started using urokinase 1000 units to 2500 units in each lumen, and that is much cheaper. You can get a 5000 unit urokinase vial for about 500 rupees. So this is again the ISN guidelines. Document all episodes of CRBSI and calculate the rate as a part of quality assurance. Remove a catheter in place in conditions of non-tunnel catheter should be removed in cases of catheter-led bloodstream infection. Cuff tunnel catheters if there is Staphylococcus, Klebsiella, Pseudomonas, or Candida, or if you have septic embolic complications like septic shock, endocarditis, myocarditis, or coexisting tunnel or exit site infections. In lower virulence organisms like Ralstonia, like Burkholderia, antibiotic locks or exchange over a guide wire may be tried. When you are stuck with a vascular access where it may be the last possible access, a judgment will have to be made in an individual case whether to retain the catheter, change the catheter over a wide guide wire, give an antibiotic lock in addition to systemic antibiotic, or remove the catheter and switch the patient to an alternative modality of treatment. Longer treatments or durations are required. A minimum period of 14 days, Staph aureus 21 days, and if there is endocarditis, 6 weeks. How should we dose antibiotics in dialysis patients? The traditional way has been to uh, deliver antibiotics, especially aminoglycosides, after a dialysis session. In article, a whole issue of seminars in dialysis, which is called Mistakes in Dialysis, Eiler and others talk about, and they quote some studies to show that it may actually be more prudent to dose aminoglycosides pre-dialysis rather than post-dialysis. There is a good scientific rationale for that, that when antibiotic or the toxicity of aminoglycosides is related to the longer period of time that the antibiotic stays within the bloodstream because of two things. And the killing of organisms by aminoglycosides is concentration dependent. So a high peak and quick removal would be better, because if once the organism is exposed to the antibiotic, they undergo what is known as first dose receptor downregulation, so that the bacterial receptors are downregulated, and then the aminoglycoside which is circulating will rather bind to the inner ear cells and produce ototoxicity and vestibular toxicity. So dose the aminoglycosides at 1 to 1.7 milligram per kilogram post dialysis, and this achieves adequate amounts of uh, uh, MIC, especially in the condition of fluid overload. So 6 milligram per kilogram pre-dialysis, dosed pre-dialysis rather than 1 to 1.7 milligram per kilogram post-dialysis may be better and might produce less antibiotic resistance, better killing, and also less toxicity in dialysis patients. The other thing that is done is frequently that vancomycin is chosen by many nephrologists and dialysis centers because of the supposed ease of administration, that vancomycin is supposed to last for 168 hours in anephric patients, that is 7 days, and that spawned the once a week dosing with vancomycin. But this once a week dosing with vancomycin comes from studies which were done in the 1990s without volumetric control machines with low flux cellulosic dialyzers, and may no longer be true 25 years later. So there are studies today, and this one was published in Critical Care Medicine, which showed that the half-life of vancomycin could be a mean of around just 43 hours, and that when you used a high flux or even a low flux dialyzer, the clearance of vancomycin from the dialysis could be as much as 24 ml per minute, and that they recommended that the IDSA recommends that vancomycin should be levels should be tested 12 to 18 hours after infusion when SLED is being used, and ensure that the concentrations do not fall below 15 milligram per ml. Now, we did some vancomycin levels in our dialysis and SLED patients. We did 32 levels in about 11 patients, and this is what we found, that only about 8%, that is 25% of the levels were above the 15 milligram per liter. and another 50% would lie between 10 and 15, and 25% of the levels would in any case be less. So even for a non-MRSA organism, in this situation you would have subtherapeutic levels of vancomycin if you did not do the levels frequently, and certainly if you dosed it every 7 days, you would end up with very low levels. So based on that, there is a recommendation: if you have a pre-dialysis vancomycin level of less than 10, then dose 20 milligram per kilogram after the dialysis. If you have 10 to 15, 15 milligram per kilogram, 15 to 20, 10 milligram per kilogram. If it's more than 25, then do not dose vancomycin after that dialysis. What is the role of antibiotic catheter locks? The 2018 ISN guidelines, in a shift of their position from the 2011 guidelines, recommended not using antibiotic catheter locks as prophylaxis, though they still recommend them for treatment. The reason for this has been that the studies after 2006 have not shown a benefit of antibiotic catheter locks as people use more of toluidine and citrate in the Western studies. And as a result of this, there is also a concern of the development of ESBL and MBL strains with prophylactic antibiotic locks. A Cochrane review in 2018 looked at all randomized or quasi-randomized control trials comparing antimicrobial locks to standard lock solutions, that is anticoagulant locks, in dialysis catheters, and they found 30 studies in about 3,400 patients. 15 studies used antibiotic lock solutions, 20 used non-antibiotic antimicrobials like citrate, like toluidine, and this is what the study showed. So irrespective of whether the incidence of infections was low or high, antibiotic lock solutions seem to show a much lower, significantly lower relative risk of developing infections, but obviously not for thrombosis. So that was not statistically significant. And the grade of the evidence, however, for this was graded to low for antibiotic locks with regard to infections and very low with regard to thrombotic events. And switch over to hypotension on dialysis. And hypotension on dialysis needs to be defined first, but unfortunately there are varying definitions. Doki 2005 defines hypotension on dialysis as a decrease in systolic blood pressure of more than 20 millimeters accompanied by symptoms. The UK Renal Association says any drop in blood pressure, and it does not define the lowest blood pressure. European best practice guidelines, again, more than 20 drop in systolic and more than 10 drop in in mean arterial pressure with symptoms and a need for intervention. The Japanese Society takes 30 and 10 with the presence of symptoms, and two more recent studies have said a systolic blood pressure of less than 90 with a drop in diastolic blood pressure, or with a drop in systolic blood pressure of 30, either or is defined as hypotension on dialysis. Hypotension occurs in 15 to 30% of all hemodialysis patients at some point of time, and more than 50% of treatments will be in a smaller number of patients will have a hypotension in at least 50% of the treatments overall occurring. Predisposing factors are supposed to be a female gender, elderly, diabetes, hypoalbuminemia, obviously, and a starting pre-HD systolic blood pressure of less than 100. The hypotension caused by imbalance between central hypovolemia and the baroreceptor reflexes. The central hypovolemia is mediated by two things. When dialysis occurs, the osmolality of the blood goes down as we remove the uremic toxins. This promotes a shift from the intravascular volume to the extravascular volume, that is to the intracellular spaces, because the intracellular osmolality is still preserved. And during this time, at the same time, we are also ultrafiltering, so we are depleting the intravascular volume. So in this situation, there is a situation where the intravascular volume is rapidly decreasing because of two factors: the drop in osmolality causing a fluid shift out, and ultrafiltration. When ultrafiltration exceeds the refilling rate, that is more than 13 ml per kg per hour, that was Jennifer Flight's analysis of the hemo study, that I think I got disconnected in between. So, cool dialysate, well, sevenfold lower incidence of hypotension. We could use a slightly higher dialysate calcium, which increases cardiac contractility. But importantly, midodrine is now available and becoming more and more available. There may be a role of L-carnitine and sertraline, and most importantly, prolong the dialysis time or increase the frequency and accurately assess the dry weight. And the dry weight is not set in stone. It needs to be reassessed from time to time as a patient loses the fluid overload that they start with. As they start to eat better because of control of uremia, their muscle mass and fat increases, and so does their dry weight. Individualizing the dialysate sodium can be done by using the OCM. Yeah. So the OCM will display the plasma sodium, the calculated plasma sodium, which the machine calculates from the inlet and outlet dialysate sodium, and that allows us to individualize. Now, it wouldn't be correct to give this patient a dialysate sodium of 140 because this patient is coming to dialysis with 129, and because the dialysate sodium has been set at 138, the patient is leaving the unit with 135. So this patient has had ultrafiltration, has had their plasma sodium go up steadily, and is going to have an increased thirst, is going to drink more water, and is going to come back in the following session with again a very much increased weight gain. Unfortunately, our clinical assessments of dry weight are subjective. It needs to have an increase in interstitial volume of 4 to 5 liters before it becomes evident. There are repeated episodes of hypotension because we have underestimated the dry weight, and the need for antihypertensive requirement may be there even if the patient is clinically dry because of, as I said, weight gain. So we did a small study in which we compared the bioimpedance. This was one of our students' theses about 3 years ago, in which we compared the bioimpedance method with the clinical dry weight. Both were measured to within 0.1 kilogram accuracy. And what we found was that the pre-systolic, dialytic systolic blood pressure at the bioimpedance dry weight was slightly lower, though not statistically so, as compared to at the clinical dry weight. The post-dialysis blood pressures were not different at all. The diastolic blood pressures were not different at all. And the post-dialysis diastolic blood pressures again were not different. There was a small drop in the antihypertensive drug requirement, and at the clinical dry weight, there were definitely more episodes of hypotension and cramps as compared to the bioimpedance dry weight. So bioimpedance analytic method for assessing dry weight may help us to avoid hypotension and cramps and enable us to set the dry weight more accurately than our clinical assessment. How do we manage hypotension? Unfortunately, one of the early signs of hypotension, impending hypotension, in addition to muscle cramps, is supposed to be seen that the patients start increasingly yawning during the dialysis session. And many nurses will notice that a patient who is yawning more is likely to get hypotension and stop the ultrafiltration even at that point of time. So stop ultrafiltration, give a head low position, a bolus of 0.9% saline. If the blood pressure comes up, resume the ultrafiltration at a lower rate. We can use hypertonic fluids in order to drag in fluid from the intracellular to the intravascular space. Importantly, do not reduce the blood flow rate. Many nurses and technicians will reduce the blood flow rate because they have not adjusted to the fact that modern machines have volumetric controlled ultrafiltration. In the days when I started doing dialysis 25 years ago, we had the machines in which the transmembrane pressure depended on the venous pressure and the dialysate pressure. Now, the venous pressure was a function of the blood flow rate. So nurses would decrease the blood flow rate in order to decrease the transmembrane pressure. And unfortunately, they sometimes continue to do this even with volumetric machines. So to summarize, how do we deal with hypotension? Systolic blood pressure either less than 90 or a drop of 30. Stop ultrafiltration, give a head low position. We have the machine's blood pump to give a bolus of intravenous isotonic saline. Reassess after 10 minutes. If it's normal, restart ultrafiltration at a lower rate. If it persists, another bolus. We could then try a colloid, not starch, of course. If the hypotension is refractory, then evaluate the cardiac status. Hypotension may be a manifestation of silent ischemic cardiac disease, and such a patient might need an ECG, an echocardiography, or even a coronary angiography. We try to combat osmolar shifts by individualizing the dialysate sodium or by doing something called sodium profiling. Today, machines allow us to profile both the sodium rate, sodium, as well as the ultrafiltration rate, and some, like the Alton machines, also allow bicarbonate profiling. This is, somebody asked me this question 3 days ago. The ultrafiltration profile 3 is a stepped profile, which is most often what we choose. What it means is that you have a starting ultrafiltration which is high, and you have an end ultrafiltration which is low. So the maximum rate, the average rate would have been 500. The starting rate is about 750, and it will drop down to around 250 in the last hour of dialysis. And what the machine also allows you is to do a mirror profile of the sodium and ultrafiltration. So it will, during the time when the ultrafiltration rate is high, the machine can set a higher dialysate sodium, and when the rate drops, the machine will set a lower than average sodium, less than 136, to remove the additional sodium which has been gained during the rapid phase. Cramps are a manifestation that might precede hypotension. So in such a situation, the treatment is roughly the same, but cramps can occur even without hypotension, in which case massaging, forced muscle stretching might help the patient. Drug treatment with either oxazepam or gabapentin, knowing that both these drugs cause a lot of drowsiness. Vitamin E and carnitine, varying success, and very effective but very toxic drug, quinine. Dialyzer reactions are of two types. Fortunately, they are becoming rarer and rarer. Type A, which will present with even anaphylactic shock and is IgE mediated, occurs in the start of dialysis and is usually these days due to the ethylene oxide disinfection. But most dialyzers today are now steam or gamma ray sterilized. So this reaction is becoming less and less significant. And more often what we will get is heparin-induced thrombocytopenia. IV iron can produce an anaphylactic reaction, but even that has become much rarer with the iron sucrose as compared to what we used earlier, that was the iron dextran. Type B reactions, late, present with chest and back pain, and are common with the incompatible cellulosic dialyzers, but not so with polysulfone. One exception is that the AN69 membrane can trigger a type B reaction in patients on ACE inhibitors, and of course sodium hypochlorite and formaldehyde, which are used. Fortunately, formaldehyde has given way to peracetic acid, so as I said, these are becoming late. How do we treat? The most important part is, do not return the blood from the extracorporeal circuit to the patient if you suspect a dialyzer reaction. Treat severe reactions with corticosteroids and importantly epinephrine. Prevention: ensure an adequate amount of priming, at least 2000 liters of saline, and use the test strips which I mentioned earlier to ensure that the dialyzer is completely free of disinfectant if you are reusing dialyzers before starting. Switch from ethylene oxide, if that was being used, to gamma radiation or steam or heated citric acid for polysulfone dialyzers. Use iron sucrose or carboxymaltose instead of dextran. And if you have a hit, then replace heparin with danaparanoid or fondaparinux. I think I'm coming up to 7:30, so I will stop over here. And
So can we have the question answers?
yeah, sure. That's why I stopped, because I thought I have gone right up almost to 7. It's 7:25. So I thought we could take questions at this point.
Usually we have till 8 o'clock, sir, so we can
Oh, you
have some
have till
questions.
8 o'clock. So then we
Yes,
have
sir.
ample time. So
Yes,
if
sir.
anybody has questions, I'll be happy to take them.
Sure, sir. Thank you.
Sir, good evening.
Good evening.
Sir, this is Dr. Vivek from Sir Gangaram Hospital. Sir,
Yes.
if you could please explain me the different modes of sodium and UF profiling and when to use
Okay.
which mode.
Okay. So today when you say modes, I think you're talking to the type of profiles available. Now, sodium and UF profiling is actually a topic in itself. So, what is our aim? If I'll try to explain the principles and what is available to you. I assume that today most of us are using the Fresenius 4008 series machines. Now, in the Fresenius 4008 series machines, there is a there are a set of fixed profiles, of which only two are possibly physiologically good profiles. Profile 1, which is a linear profile, and profile 3, which is the stepped profile, which I showed you. Now, in these profiles, the aim of profiling of sodium and of ultrafiltration is that you increase your ultrafiltration rate at the time early in the dialysis when the osmolality, the plasma osmolality is at its highest. So during that time, the patient will tolerate more fluid removal than at a later stage where the urea levels are dropping down, where the plasma osmolality is low, where fluid is moving into the intracellular compartment, and at that stage ultrafiltration will not be tolerated well. So when you choose a profile, as I showed in my slide, if your average ultrafiltration over a 4-hour period with no profile would have been about 500 mils per minute, then in the profile during the early phase, the machine will take out at a rate of 750 and maybe drop down to 250 in the last hour at a time when the osmolality is low. By doing this, now what the machines will today, the 4008 series machines do is they only allow you to choose mirror profiles for sodium and ultrafiltration if you want to do more. So you cannot, for instance, choose a linear ultrafiltration profile and a stepped sodium profile, because that could mean that there would be a point in time when the sodium is low and the ultrafiltration rate is high. So the machine will only allow you to choose compatible profiles. So you will be choosing the same profile, ultrafiltration profile 1 with sodium profile IL1, which means that there will be a linear decrease in the ultrafiltration rate. At the same time, there will be a linear decrease in the dialysate sodium. When you profile the dialysate sodium, if your prescribed sodium is say 135 or 136, then and you choose a profile, a linear or a step profile, during the early part of the dialysis session, when you want to increase the plasma osmolality, when you want to do more ultrafiltration, the machine will keep the sodium at say some level. It allows you to choose what they call the starting sodium. So if your prescribed sodium is 136, you can choose a starting sodium of 138 or 140, which means that the machine will keep a sodium of 140 during the first hour of dialysis. During the second hour, it will keep it at around 138. During the third hour, it will be 136, which is your prescribed. And during the last hour of dialysis, when the ultrafiltration rate is low, the machine will keep the sodium at a level of say 133 or 134, which is below your prescribed value. So all the sodium that the patient gained during the first 2 hours of dialysis will be removed during that last hour. So that is the that is the principle at which sodium profiling works. Having said that, the studies show that in at least in chronic dialysis, sodium profiling has not proved very useful. It has worked in, there is a meta-analysis of sodium profiling in SLED, which has shown a benefit in critically ill patients. But in chronic dialysis, sodium profiling and hypotension for decreasing hypotension was not very useful.
Thank you so much, sir.
Somebody has asked a brief review of various machine alarms and their interpretation and management. Now, that's going to be very difficult to show you without the necessary slides on the screen, or best of all, for me to show you at the bedside on a patient who is undergoing dialysis. But I'll try, though I don't have the slides in front of me at this moment, because that one, your machines generally have about 5 alarms. So there is a set of alarms on the blood side, as I mentioned in my lecture 3 days ago, which is a very low arterial pressure, a very high venous pressure, or an air detector. is it possible for me to share my slides again about the air detector? No, forget it. Doesn't matter. So the air detector, these three are blood side alarms, and you have a conductivity alarm, which is on, and a blood leak alarm, which are dialysate side alarms. So these are the 5 basic alarms which most machines will have. There are some others which are less important. If you have a very low dialysate pressure, very negative pre-pump pressure, then your access isn't giving enough blood flow compared to what you've set. Your arterial chamber will start collapsing, and your machine in such a situation will flash an arterial alarm. At some point of time, if the arterial alarm goes out of the limits, then at that point of time, then you will have the blood pump will stop and the line will be clamped. The venous alarm is exactly the opposite. It's in the post pump segment where all the pressures are positive. So in that situation, what you will have is a situation where either there is a very high venous alarm. A high venous alarm is caused by a blocked needle or a clot in the venous bubble chamber, or a clot between the venous bubble chamber and the patient's dialysis needle. Now, a high venous alarm means that the pressure, the blood pump cannot push. In such a situation, again, the blood pump will stop and the venous line will clamp. If you have a very low venous alarm, in its said, there are a lots, and if you go to the website of MAUDE mod website, where anonymous reporting of dialysis accidents is done, then you will find more than one episode reported of venous alarms not going off when there is disconnection of a patient from the machine. So unfortunately, the reason for this is that the venous alarm is set too high, or the alarm limits are set too wide. Now, with the Althin and Fresenius machines today, the alarm limit is set automatically within 5% of the venous pressure as it occurs at the start of the dialysis. But you can override these if an alarm occurs and you merely press the reset button. So what you need to do is to see why an audible alarm, why a venous pressure alarm has occurred in this situation, instead of merely resetting. And that it also mentions, the website mentions that in such a situation, always examine the needle point, the needle axis, and the connection between the venous bloodline and the dialysis needle. The third alarm, which is on the venous side, is the air detector alarm. The air detector alarm, unfortunately, again, in the Fresenius machines can be bypassed, and many of your technicians will know how to do it. If you take an old 25 naya paisa coin and place it in the venous bubble chamber, then you will not get a an air detector alarm. The other thing that is often done is that, which is not remembered, is that micro bubbles of air, which are less than 50 microliters, will not trigger a venous alarm, an air detector alarm. So in this situation, micro bubbles can actually pass through the air detector. The way to prevent micro bubbles from reaching there, you know that air will rise to the top of the bubble chamber. So keep a high bubble chamber so that the force that by which the pump is pushing blood is not enough to push the micro bubble out of the air detector chamber. One of the problems that arises, which I mentioned to you when I showed it to you 3 days ago, is that various different blood sets are available, and the venous bubble chambers are of different diameters. Now, each time you change a blood set, you need to recalibrate your air detector. Otherwise, a thin film of air on the outside of the venous bubble chamber, but between the bubble chamber and the air detector, gives you a frequent air detector alarm. And what nurses do in such situations is to drop a bit of saline into that space so that the alarm stops. Now, when you do that, you're actually disarming your air detector, because after that, even if the bubble chamber, even if air does manage to pass through, the machine will detect the saline and the air detector alarm may not go off. The second thing that happens is eventually that saline works its way through those piezoelectric crystals over there in the air detector, and it precipitates on the circuit board inside the air detector and shorts it. And then you have to replace your air detector, which costs about 35,000. So the third and the other two alarms as a conductivity alarm means your dialysate conductivity. Now one can, again, I could talk for about 15 minutes to half an hour about conductivity, but the main thing is that your dialysate does not have the proper composition. You need to check your concentrates, you need to check the water. And the last one is the blood leak detector. Now, if a machine is giving a blood leak detector, then you need to make sure that your dialyzer hasn't ruptured. So in this situation, what you would have to do is in this situation, what you would have to do is to check the dialysate with the multisticks whether it actually contains blood, the dialysate leaving the dialyzer. If it does, then you need to stop the dialysis and change the dialyzer. If it does not, then you need to check your blood leak detector, because if precipitate has formed on the photoelectric cell there, then you need to clean that rather than to change the dialyzer. So a false blood leak alarm can go off if there is a precipitate on the photoelectric cell. Why is yawning the first sign of hypotension? Actually, I don't know. But we all know that it happens. Even nurses know it very well. I don't know why it happens. How is reversing of needles done? I'm not sure I get that. So how is reversing? Well, if the nurses find that the blood, either you are getting an alarm, either an arterial pressure alarm or a venous pressure alarm, they may just reverse the needle. More often than that, what they do is to reverse the catheter. When you have a tunnel cuff catheter, they will reverse the lumens. So if one lumen is not giving adequate flow, and that's supposed to be the outflow lumen, they will reverse it and connect to the inflow. And you could actually, if they don't tell you that they've done it, you could miss the start of a fibrin sheath in the vein. Oliguric AKI and serum sodium 170. How to do dialysis? Excellent question. There are lots of options. First of all, what is the highest sodium that your machine allows you to set? If you have a Fresenius 4008 machine, it's 148. If you have an Alton machine, it's about 160. If it's a B Brown dialogue, it allows you to go to 170. If it's a Nipro machine, it again allows you to go to 170. So no problem if you have a machine that's allowing you 160, 170. You also want to limit the rate of drop. So you could keep a low blood flow, and you could do a co-current, that is, keep your dialysate flowing in the same direction as the blood, so that your gradient for diffusion disappears halfway along the length of the dialyzer. So you are reducing the efficiency of your dialyzer, and you're not allowing the sodium to come down below a particular level. If you don't, however, have a machine that allows you to go up to 160, then you're using a dialysate which has, say, a maximum possible sodium of 148, then of course use a co-current dialysate flow. But what you can also do is to do an isolated ultrafiltration, and you can give a replacement fluid with perhaps normal saline. So in this situation, you'd be, for every liter of fluid that you removed with which has a sodium of 150, of 170, that's the ultrafiltrate, you replace it with a liter of saline, which has a sodium of 154. Your correction will be very slow, not more than 1 millimole per hour. You do that for about 4 hours, and you will generally have done enough, or you can go much slower than that, keep much lower volumes, don't even do a liter of exchange per hour. And of course, if you have a CRRT machine, then you would do CRRT. If you don't have a CRRT machine, you can also do peritoneal dialysis, acute peritoneal dialysis, which will correct the sodium at a very gentle rate. What should be the difference between the prescribed sodium, serum sodium, and the prescribed sodium? Now, it depends here what you're treating. Are you treating hyponatremia or hypernatremia? If you're treating hypernatremia, you have a little way to play off with, because you can give a little bit of free water to limit the amount by which you are decreasing decreasing the serum sodium. You can do isolated ultrafiltration. If you are treating hyponatremia, then minimize the gradient, and that may be very difficult. As I said, if you have a Fresenius machine, the lowest value is 128. If you have an Alton, it's 130. If you have a B Brown machine, it's 120. And if you have a Nipro machine, you can go down to 110. Now imagine it's a Fresenius machine with 128, and you have a patient with a sodium of 110. So the minimum gradient you can keep is 18. So you'd keep 18 in such a situation. If you have the option of keeping a smaller gradient, then you keep a gradient of 8 to 10 and do a co-current flow to limit the speed of correction, and extend your dialysis session if you want to do the correction slowly and over a longer period of time. So smallest possible gradient and longer hours of would be the way to go. I think if there are no questions anymore,
Do you have any more questions?
doesn't appear. So in that case, thank you everyone.
Thank you so much, sir, for this
Okay.
nice session. So can we share the recording with the students, sir?
Yeah, no problem.
Okay, sir. Thank you so
Okay.
much, sir.
Thank
Thank you
you
for sparing your
and good
time.
night.
Good night, sir.